So I'm Jesse McCarron. I'm one of the shoulder elbow guys at Rebound. Thank you all for coming. We're very excited about this being the first year. I do want to take a quick moment just to acknowledge the sponsors for this who allowed us to put this on. People's Injury Network Northwest, American Medical Concepts, Abbott, Medtronic, Pew Synthes. These are all corporate organizations that are in our community that we Rebound work with daily, and they are the reason that we're able to provide this CME for free. And you know, they provide our financial support for this because they recognize the value of this type of ongoing education, and I greatly appreciate the fact that they allow us to do this and give us this opportunity. And I hope you guys find it useful too, but they do deserve thanks and recognition. So I should also start by apologizing. My talk is actually a little bit mislabeled. I was originally planning on talking about surgical treatment of shoulders, but as I started putting the talk together, I realized that really from a practical standpoint, that is not very valuable for you guys. I would suspect that for most of you on a yearly basis, maybe you have a couple of patients who are undergoing shoulder surgery, but on a day-to-day, week-to-week basis, it's probably not very relevant to the patients or the athletes you're taking care of and the things you're doing. So I decided to refocus this talk a little bit and step back and hopefully provide something that's a little bit more valuable and useful to you guys on a daily and weekly basis. With that in mind, I should point out there's no disclosure slide here, but I don't have any disclosures or conflicts that are relevant to what I'm talking about here today. What I am going to talk about is a review of basic shoulder anatomy and biomechanics. I find even amongst my orthopedic colleagues who don't do shoulder and elbow stuff, oftentimes the shoulder seems kind of like a black box, and I really don't think it has to be. And I think if you sort of have just a foundational understanding of the anatomy and the biomechanics of how the shoulder works, your ability on a daily basis when you're seeing patients who come to you with shoulder symptoms or specific shoulder injuries, it'll be a lot easier for you guys to sort out what's going on and figure out where you want to go with those patients from there. So I want to talk some about the anatomy and biomechanics. And then we'll move to sort of on-field assessment. What do you do? How do you look at these patients? How do you figure out what's just happened when your patient, when your athlete comes off the field of play complaining of a problem with their shoulder? And then, of course, we will talk about surgical treatment for these injuries, and also, how do you figure out both on the day of the injury as well as after surgery when those people are ready to return to play. So anatomy. So start off with the basics. Shoulder bone structures. You have your scapula, you have your humerus, and you've got the clavicle. Those things make up the shoulder girdle. If you spin the scapula 90 degrees, so you're looking end-on at it, you're looking at this pear-shaped glenoid socket. So that's the socket of your ball and socket joint. Surrounding that glenoid socket, you have a ring of soft tissue, which is the labrum. I usually think about it as kind of analogous to the meniscus in the knee. It creates a soft tissue bumper that actually deepens the sort of the socket itself, and it also is the attachment point where the joint capsule comes in and inserts around the edges of the socket. So the labrum and the surrounding joint capsule, which you see in the lower right, create the static stabilizers for the shoulder. If you then go to the next layer, you come to the rotator cuff muscles, which are the dynamic stabilizers for the shoulder. And for your patients with symptomatic instability, it's a problem with some combination of the static stabilizers, the labrum and the joint capsule, and the dynamic stabilizers, which are the rotator cuff muscles. So those rotator cuff muscles in front, it's the subscapularis. Across the top, it's the supraspinatus, and then coming down the back, you have the infraspinatus and the teres minor. Those four muscle groups are your rotator cuff. Where they come and actually attach onto the ball of the shoulder joint, they actually blend into a confluence of tendons. So there's not a distinct transition from one into the other as you come around the shoulder, but as you move back onto the shoulder blade, they do separate into different muscle groups that have varying roles in that stability process. Over top of the rotator cuff muscles, we then have all those larger muscle groups that we immediately and easily recognize the pectoralis anteriorly, the deltoid, which wraps anterior, lateral, and all the way around posterior aspect of the shoulder, and in back, again, deltoid again. And you can also see some of the posterior rotator cuff muscles sort of come out onto the posterior shoulder blade underneath as they come medially from the deltoid. So, shoulder biomechanics. The shoulder is a very large ball sitting on a very small socket. Think of a golf ball sitting on a golf tee. And that provides the shoulder with 6 degrees of freedom. The shoulder has more range of motion than any other joint in the body. But that range of motion comes at a cost. And that cost is that there's no inherent bony stability for the shoulder. The only thing that keeps the ball on the socket is that combination of those static stabilizers and the dynamic stabilizers that we're talking about. The muscles, the larger muscles that are more superficial, we're talking about your pectoralis, your deltoid, we're talking about your latissimus on your back, all these big muscles, those are the muscles that actually affect most of the large motions that you do with your arms or that your athletes are doing on the field of play. Those provide sort of the active big motions for the arm. But the rotator cuff, deep to those superficial muscles, is what provides both that dynamic stability of the shoulder that then allows the larger muscle groups to work. And it's also the rotator cuff that provides this fixed fulcrum that allows the ball to pivot or roll on the socket instead of just getting pulled one direction or the other and essentially brought partway off the socket by the larger muscle groups. If the rotator cuff can't perform its function of dynamic centering of the humeral head, your shoulder can't create a fixed pivot point around which the ball needs to rotate to bring your arm up over your head. So this is what that looks like if you actually think about the biomechanics. So if this blue point is where the deltoid inserts on the humerus, okay? And if the deltoid muscle contracts, all it really does in isolation would be actually create a upwards vector. But that's not particularly useful for your shoulder. If that deltoid pulls unopposed on your shoulder, the only thing it does is drive the ball, the humeral head up underneath the acromion, which pinches your rotator cuff and gives you pain, okay? That's subacromial impingement. However, if you have your rotator cuffs, especially the anterior and posterior rotator cuff muscles, functioning properly, those have a medial and downwards vector, which when you add in to the deltoid, will create that fixed pivot point around which the ball will rotate. And that allows you to then create that fulcrum that allows the shoulder to then elevate. So that's how these muscles interplay with each other. So now that we sort of understand the anatomy and the biomechanics of what's going on, let's sort of look at on-field assessment and the injuries that your athletes are sustaining. So there are really 3 basic mechanisms of injuries that you're going to see for most of your shoulder injuries. There are the direct blows to the shoulder, like you see in the rugby player on the lower left. There are the indirect loading or rotational forces that are applied through the arm without necessarily direct contact to the shoulder itself. And then there are the sort of repetitive overuse injuries. You know, think about your pitchers, volleyball players, that sort of thing. So, mechanism of injury with dislocations and subluxations. These are either going to be anterior, which is by far the majority of these that you're going to see, or they're more posterior. The anteriors tend to be a little bit more dramatic, a little bit easier to pick up. Usually for the anterior dislocations, this is an injury that occurs by a rotational force applied to the arm when the arm is in some degree of the elevated, abducted, and externally rotated position like we're seeing on the left. It will often come with a acute pain in the front of the shoulder. It could be a full dislocation where the shoulder is very obviously dislocated as the player comes off the field, or it could just be a subluxation event where they stretch or tear some of the anterior static stabilizers, the labrum of the joint capsule, but the shoulder is not actually out of joint. And that, you know, can present simply as shoulder pain, but without an obvious dislocation at the time of injury. The posterior dislocations are actually a little bit trickier to pick up, I think, because in part because a lot of times it's not as dramatic an injury mechanism. You know, the posterior dislocations or subluxations are often just an axial load. So think your blockers in football. You have your arm out in front of you. That the hand gets struck and that drives the shoulder out the back. Those people are going to have pain along the posterior joint line. It's less likely to actually stay dislocated out the back, so you're not going to have that necessarily obvious dislocation. And it's also important to point out that even if it does, if you have one of those rare patients who is dislocated out the back, posterior dislocations can actually be really subtle and hard to pick up on physical exam. They even get missed in the emergency room, and even the x-ray findings are not necessarily as dramatic as you might expect them to be. So if someone is dislocated out the back and they've stayed dislocated, their arm is going to be fixed in some internal rotation. They're not going to be able to externally rotate it, but other than that, it may be really hard to figure out on the field at the time of the injury that they're actually dislocated. So let's move on to rotator cuff, bicep, and superior labrum. These are what you usually think of as your throwing or your overhead athletes. It can be repetitive use type of stuff, like the pitcher. This obviously puts a lot of rotational strain on the labrum, and especially during the deceleration portion of the throwing maneuver. That can both stress the posterior joint capsule and posterior labrum. It also puts a tremendous amount of strain on the rotator cuff, and so you can get injuries there. The middle picture here is a great mechanism to sustain a superior labrum or a bicep anchor injury. You have this arm that is abducted, externally rotated, and then you're going to apply a huge force through this bicep, and that bicep is going to, that force is going to transmit down along the long head of the bicep right to the superior labrum, and that can cause a tear there, either a one-time traumatic event, or it can be more of a repetitive sort of repeated smaller injuries that accumulate over time, which is what you start to get a sense for in this picture in the lower right. So this picture in the lower right is an MRI of a right shoulder. The funny looking triangle to the right side of the picture is the glenoid socket. The ball in the middle is the humeral head, and in this position, that arm is in the abducted externally rotated position, and that white arrow is pointing to where you see the superior rim of the glenoid with the superior labrum directly contacting the deep surface of the rotator cuff. And so if you're making hard contact between those two surfaces time and time again, that can either cause a tear in the labrum or it can give you an articular-sided rotator cuff tear, both of which can be problems in your overhead athletes. Other direct blow types of mechanisms. The direct blow is one that very commonly causes these AC joint separations. And it can be a hard blow to the top of the shoulder. It can be a fall onto the lateral or even the posterior aspect of the shoulder that makes the shoulder blade collapse in and the clavicle basically dislocates up and over the top. Sometimes you have dramatic x-ray findings, sometimes you don't. It can be fairly subtle, but AC joint injuries are very painful even if they're not widely superiorly displaced. So it's worth mentioning stingers too. So stingers is this sort of generic term that's often used for when someone comes off the field with painful paresthesias, numbness that went down the arm. A lot of times that is a traction. Well, anytime someone comes off the field with those symptoms that they've had an acute stretch injury to their nerves. And that can occur at a couple of places. It can certainly occur from a lateral bending or a forced maneuver in the neck that actually stretches the nerves where they exit from the cervical foramina. But you can also get those distal paresthesias associated with a stretch injury that occurs actually at the shoulder girdle. So for example, a wide AC separation where the scapula gets driven down, that's going to lengthen that area that those nerves are trying to traverse as they come through the top part of the thoracic cavity and chest wall, and that will stretch the nerves and cause zingers. Dislocations, especially anterior dislocations of the shoulder, can cause zingers too, because the brachial plexus, as it then transitions into the axilla and goes down the arm, a lot of those nerves traverse right across the front of the glenohumeral joint, and so if the shoulder dislocates out the front, that's actually going to put direct stretch and actually impact some of those nerves that are coming across the front of the shoulder and can give you stretch injury there as well. So how do you evaluate these people when they're coming to you with symptoms at the time of play or immediately after the time of play? So one of the most valuable things is just figuring out what the mechanism of injury is. If you really know what the position of their arm was, how they got hit when the injury occurred, that allows you to narrow it down dramatically. If you know if someone's coming to you with shoulder pain and their arm was somewhere in here when that started, well, they didn't dislocate their shoulder anteriorly. Conversely, if it's a thrower, if it's a pitcher, understanding that this has been something that has been accumulating over time and there wasn't one specific injury, that directs you to these overuse type injuries as opposed to an acute specific one-time event. So on the sideline, you need to check, see where they're painful. If they have their arm out front, they're painful in the back, you're probably looking at a posterior labral injury, whether they subluxed or dislocated. Anterior joint line pain, if their pain is all lateral, that's going to be rotator cuff that you're getting at over here. Obviously, if you poke at their AC joint, and that's where they're telling you their pain is, it's probably an AC sprain or AC separation. After that, getting a sense for, do they have full active motion? And a lot of people are confused as to sort of how to go through with a shoulder that has 6 degrees of freedom. What are the relevant range of motions you need to test? As someone who does exclusively shoulders, you can narrow down your range of motion for the shoulder with 3 motions. That's all you need to do. All shoulder motion in any plane, all positions, is some combination of external rotation, active elevation, and internal rotation. I've never checked abduction in the last 12 years in the office. It's not relevant because it's actually a combination of the neutral rotation and a forward flexion. You can, if you have someone come off the field and you check their external rotation, their forward flexion, internal rotation, and make them do it on both sides, you're going to immediately know if they have range of motion deficits. And it is important to check the other side because everyone's motion is different. Some people really don't get up past 170. Some people get up to full 180. Some people, your older athletes, may only get up to 150 or 60. And if you have someone who gets up to 150 or 60 and you're only checking one side, that could be their normal, or it could be a dramatic 20-degree loss in elevation, right? So check them together, external rotation, forward flexion, internal rotation. And then if they're not able to go through that active motion, or if there's an active range of motion deficit and mismatch one side to the other, if they will allow you, gently, cautiously checking passive motion can help. If they can't bring their arm up over their head, but you can gently bring their arm up over the head with assistance, well, maybe it's a stinger. They ding the nerves and they're not getting good nerve function, or maybe it's just pain inhibition. If they can't raise their arm up over their head and you gently try and put it through range of motion and it won't go through range of motion, then it's probably a dislocated shoulder, right? So these passive active mismatches can help you. And then of course, checking neurovascular status, make sure that they've got intact symmetric sensation in the hand, forearm, up here at the shoulder, lateral deltoid. Check those things. So on-field dislocations. And we can go through a little bit more of this when we have our physical exam breakout sessions. We can talk about how to deal with these on the field of play. But the vast majority of these that you're going to see are going to be anterior dislocations. There's usually visible deformity associated with this. As I just mentioned, they're not going to have any active or passive motion. And for most people who have an anterior shoulder dislocation, the reason that shoulder is staying dislocated is because the surrounding musculature has gone into spasm and it's holding the ball out of the socket. So as you get a hint for on this x-ray of an anterior dislocation, what's really happened here is as the ball slips out of the socket, the surrounding muscles spasm and they try and pull the ball back in. But what will happen is that the posterior aspect of the humeral head will impact on the anterior rim of the glenoid and it'll get locked there. The only reason it's locked there is because those surrounding muscle groups are holding it in against there. And when those muscles eventually fatigue, a lot of times that shoulder will spontaneously relocate. So with that in mind, if you have a patient that is willing to cooperate, if there's an anterior dislocation and it's going to take 5 or 10 minutes to get them to the car, whatever sort of transportation you need to get them to the emergency room, there are a couple of gentle techniques you can try and use to see if you can get them to relocate there on the field. It's at least 2 or 3 times a year that I have some poor teenager that comes to me in the office and describes how they dislocated their shoulder playing soccer, and they went to the emergency room and they sat in the emergency room for 2.5 hours with a dislocated shoulder before it gets put back in. So if you have some techniques that you can use to get them back in on the field of play, that's great. The two, you certainly don't want to do anything forceful, and if you have any concerns, you shouldn't try it. However, 2 really safe mechanisms. One is just a weighted pendulum. So if you get them to relax their arm, let it hang by their side, and if there's any way to apply just a steady 5 or 10 pounds of traction to their arm, and that can be you or someone who's assisting you, just gently holding their wrist and just giving just gently holding a little pull there. If you have like something that's weighted, sometimes you can actually have them hold gently hold in their hand a large water bottle or something like that, just even a couple of pounds. And you wait, usually those muscles, if they are trying to relax, usually those muscles will fatigue over about 5 or 10 minutes. And if you just leave it alone, sometimes it'll spontaneously reduce. The other way to do this that requires a little bit more involvement on your part, that can be a very effective method, is called the Milch maneuver. I'm not going to go into it much right now, but I'll show it to you in the physical exam breakout sessions. This does require that you actively manipulate their arm, but it is a nice, safe, non-traumatic reduction technique that can be successful without the use of any pain medication or anesthesia. I actually still use it sometimes in the emergency department because sometimes it can be successful even before they can draw medications in the emergency room. So return to play at the time of the injury. If they have full active range of motion, they have full strength, and they have no apprehension. That is to say, you can position them out here and externally rotate them, and they don't express any concerns or pain on the anterior joint line. And I think it's also important to check for posterior apprehension. So that would be having them put their arms in front and actually load to the arm. They have no apprehension and they have a normal neurologic exam. They should be safe to return to play on that day at that time. For those people who aren't going to return to play, or for those people who are having pain after the game is over, if they did return to play, obviously if you have any concerns about a dislocation or a fracture, those people need to be seen quickly. However, if you're not worried about a dislocation or a fracture, you can probably skip the trip to the emergency room or urgent care. Most of the people I see with acute injuries do end up going to the emergency room first because they're having a lot of pain, but there's rarely anything useful, frankly, other than just reassurance that comes out of that emergency room visit. So if you're worried about a dislocation, if you're worried about a fracture, if they have any persistent neurologic deficits, those people should be evaluated urgently. Otherwise, timely referral to a specialist is probably okay, and you can skip that time in the emergency room on that day. In-office evaluation. So when they come to see me a couple of days later, let them give me a history. Where do you hurt? What was the mechanism of injury? We look for provocative activities. So for example, if you check their bicep and any bicep activity causes deep shoulder pain, I'm starting to worry about a slap tear. You put them in positions like the fully elevated position. If that causes lateral deltoid pain, I'm thinking about the rotator cuff. And you obviously check for apprehension, so the abduction, externally rotated position, for anterior instability. The jerk maneuver is what we use for posterior instability, which basically means you bring the arm across the body, bend the elbow, and you apply a little force along the posterior joint line. And if that's hurting them, then you're worried about posterior labral injury. We always start with x-rays. They're usually not particularly helpful. Then we typically go to advanced imaging, which is most often an MRI for soft tissue. If you've had a dislocation, you're worried there may be a chip fracture off the glenoid, then you're talking about a CT scan to more carefully evaluate that bone. So rotator cuff. Most rotator cuff injuries that you're going to see in your athletes are simply overuse injuries, and they need to be rehabbed, but they don't need surgery. These people are not going to have rotator cuff tears. They're extremely uncommon in these younger patients under the age of about 25. So for those people, they can still do most of their things as long as they're avoiding the aggravating activities. Physical therapy is the key here. You're trying to make sure that those anterior and posterior rotator cuff muscles are really strong enough to provide that dynamic centering of the humeral head and to keep that subacromial space open. It's really important to include the periscapular muscles in this rehab process as well, because the shoulder girdle as a whole, 2/3 of the motion for the shoulder after you get above 60 degrees of elevation actually comes from the shoulder blade and not actually from the ball and socket joint. So for all this activity up here, that's actually more motion from your shoulder blade than it is actually from the ball and socket joint. So you need to make sure that that's part of your strengthening and rehab process. Return to play is usually 4 to 8 weeks. It's really based on symptoms, and you want to make sure they have full range of motion, that they have symmetric strength, and they don't have any pain with sport-specific activities. Instability. So for first-time instability, for first-time dislocations, the default really should still be to assume that most people are going to be okay with non-operative treatment. Once you have your second dislocation, the chances of you having a third, fourth, fifth without surgery is very high. So that first dislocation, you want to think about non-operative treatment, but for the second, you really need to now talk with these people about surgery, because this is going to keep happening. There are certain situations where we do operate on people for first-time dislocations, and that's still, I think, an evolving concept. I don't think we're good at picking who's going to have that second dislocation after having had that first one, but we do know risk factors for that are being male, being young, under the age of 25, and participating in contact sports. Right? This is an MRI of a left shoulder. Patients lying on their back, you're viewing them from their feet. So top part of the socket is the anterior joint capsule and labrum, and you can see the separation here between the anterior glenoid rim and the labrum. So that's where that labrum and joint capsule have peeled off the front of the socket. Okay. So superior labrum and biceps injuries. These rarely heal without surgery, but it's also really hard to establish a diagnosis. I am more concerned about a labral injury, a superior labral injury, if patients have deep-seated shoulder pain when they're trying to do bicep-specific activities. Don't rely on MRI reports for superior labrum injuries. MRI has been repeatedly shown to be terrible at diagnosing labral injuries. It both misses labral injuries that are real in the superior portion of the joint capsule, and it calls a lot of labral injuries that turn out to be false in the superior labrum. So MRI is usually done if they're failing non-operative treatment and you're thinking you're going to have to go to surgery, but I put very little stock in what the MRI is showing me. I tell everyone that it's going to be based on what it looks like when I get in there, and the MRI for me is frankly more important because it rules out other things, make sure there's not something else that I'm missing more than confirmatory for a bicep or superior labrum injury. So at the time of surgery, this is what a normal bicep origin on the superior labrum looks like. This is a right shoulder. You're viewing it from the back towards the front. You're catching a little bit of the ball of the humeral head on the right side of your screen. This is the socket on the left side of your screen, and this rolled tissue around the edge of the socket is the labrum with the bicep originating off the top. And you can see this is nice and clean. This is the bicep, long head of the bicep tendon itself as it exits the shoulder joint, shiny, smooth, that's what you want to see. This is a normal anterior inferior labrum. You're looking now at anterior joint capsule at about maybe the 4 o'clock position, anteriorly and inferiorly. So this is the area you'll tear with an anterior instability and anterior dislocation. So this was a case of a 17-year-old male. He dislocated playing basketball. He was going up for a rebound, got hit hard, dislocated. Closed reduction in the emergency room after about 2 hours. X-rays were normal. He actually was already gaining cautious, good motion even a couple of days after the dislocation. He would gently bring his arms up overhead in the office. It seemed like a very reasonable option for non-operative treatment. We put him through physical therapy. He got back to full strength, good range of motion. He was not reporting any apprehension. 10 weeks after his initial dislocation, like his second day back playing basketball, he dislocated again. So we got an MRI at this point. The MRI is right here. It shows two things. The first of these is this right here. That's edema in the ball of the humeral head. Remember, when that shoulder dislocates, the ball rebounds back and it hits the front of the socket. So that's a bone bruise where the posterior superior aspect of the humeral head hit the anterior glenoid rim. That is proof positive that this guy dislocated, not like there was any question about it. And then the second thing you see here is his labral injury, which is this right down here. This is joint capsule. That's glenoid. This is edema and a displaced capsulolabral tear off the inferior rim of the glenoid. This is what we see at the time of surgery. So for this, we rotated the patient onto their side. So they are lying down with the right side up. So think of the glenoid socket as a table underneath you. That's what you're seeing right here. Ball of the humeral head is above, and what you're not seeing in this picture is a rolled labrum, which should be running around the rim of this socket. So this is where his labrum has torn off. As we look around posterior inferior, this is the glenoid, this is his joint capsule. That's not supposed to be there. That's where the capsule is separated from that labrum. So we go in there, we drill some holes around the edges of the socket. We call them anchors, but they look like little plastic bullets. We put those in around the corners of the glenoid, and then we take the sutures from those anchors and we tie the labrum back up and reduce it back into place. So you can see these are same locations before and after. Anteriorly, and you can see we've recreated that rolled bumper along the inferior rim, and then posteriorly you can see we've gotten rid of that cleft, that divide between the glenoid and the capsule. So he just rested for 6 weeks, then he started physical therapy. He was back at full activities of daily living, but not any sports at 12 weeks. At 12 weeks, we started adding weight training. He was released to sports-specific activities he was started on sports-specific activities at around 4 months, released back to high level, but not contact at 6 months, and then full unrestricted activities at 9 months. He was a little bit slower with his rehab. Most people are going back to full contact sports at 6 months, but because his inferior capsulolabral injury was more severe than most, he also developed more stiffness after surgery, which I was actually okay with. It means he healed it really well. But at 6 months, he still had a mismatch motion, active motion deficit, so I wasn't ready for him to return. It took him an extra 2 months to get that back, but he eventually did get full active range of motion and went back to full return to play. So one last case. So this is a superior labrum tear, 18-year-old soccer goalkeeper. He sustained a hard sort of fall in a dive on an outstretched arm. He sustained a type 1 AC separation. That was actually 4 years ago. That got better, but then he started having a deeper seated pain that was exacerbated by several smaller minor injuries. He had a little bit of AC joint tenderness and a little bit of scapular dyskinesis. The shoulder blade wasn't moving properly when I first saw him. His x-rays were normal, so we got him into physical therapy. Scapular dyskinesis improved, but he now had this very clear, deep-seated pain. He couldn't put his finger on it. He was like, it's down in there somewhere. And he was pointing to the superior labrum. It's incredible. Even your uneducated patients will actually, for a true superior labrum lesion, they're pretty darn good at pointing to where it is, even though they don't know what they're pointing to. So he actually did not have any provocative symptoms on bicep testing specifically, but he kept just reporting this deep shoulder pain. So we got an MRI, and this was his MRI. So I told you not to trust MRIs, but this is pretty definitive for, this is the superior labrum. There's a lot of fluid coming up underneath the labrum, and there's sort of a complex tear right here. So he went to surgery. Remember, this is what normal looks like. This is what his look like. And you can not only lift it up off the socket, But in fact, if you come on top of it and sweep it down, it'll drop into the joint, which is why these people will get mechanical symptoms, because that labrum will fall into the joint, it'll get incarcerated between two joint surfaces, and it's just like having a bucket handle tear in the meniscus. It'll be extremely painful until that labrum gets out of the joint. So normal injury, that's what it looks like when we've repaired it. Similar to the inferior instability, rest from 6 weeks, start rotator cuff and scapular exercises for no resistance exercises for the bicep until 12 weeks. At 12 weeks, we start them on bicep activities, sport-specific strengthening at 4 months, and then full activities at 6 months. So, forgive me, I ran a little long. I hope this was useful. But these shoulder injuries are common. I think if you have a good understanding of the anatomy and the biomechanics, you're going to be able to sort out what's going on with your patients, and the mechanism of injury is key here. Some of these patients are going to need surgery, but most of the patients you're seeing with these shoulder issues aren't going to need surgery, and you just need to know how to figure out when they need a more urgent referral and when they just need some rehab and some physical therapy. I appreciate your time. Thanks for letting me talk, and